Hello, today we're discussing obesity. We've all faced patients that are diabetic, their BMI is 30, or their Asian diabetic BMI is 27. And we know that sending these patients for weight loss surgery produces almost 80% remission in the diabetes. Besides this, we have several patients that are obese and have a hard time losing weight. And most of us struggle with weight gain. So, this talk deals with all these issues and looks into physiological and biological backgrounds. First of all, what is the best way of assessing basic metabolic rate? What happens in obese people that they can't lose weight, that they're tired and have a brain fog? How do you break out of this cycle? Do we all have to undergo metabolic surgery? Should we be taking the GLP-1 inhibitors? We'll address all of these things. And in addition to this, what happens with aging to our muscles and mitochondria? So let's get on with this. First of all, we commonly use basic metabolic BMI for the patient. The problem with BMI is it's a static measure. It is doesn't account for the fact that someone may have a lot of muscle and therefore the BMI may be high. Um, Now, as we age, skeletal muscle declines 3 to 8% per decade. Strength declines about 1% after the age 30. Now, if you use normal BMI, we can miss severe metabolic derangement and sarcopenia. A common, easy clinical method to diagnose is to do a waist to height ratio, or at least measure the waist. Now, the gold standard is heavy water. Basically, you use deuterium, which is heavy hydrogen, along with oxygen 18. Have the person drink the water. This goes back to work in the 1940s, where people did this in mice. It was too expensive. Subsequently, the price went down, so they started doing human studies. Essentially, the hydrogen component is only excreted in urine. The oxygen component is also excreted in carbon dioxide as well as urine. Therefore, when you track the um, ratio between this oxygen and hydrogen, you can come up with a basic metabolic rate. As you can see in the figure, the heavy labeled water, hydrogen is processed, and you can think of it as K2 in this equation, where K2 is the hydrogen going out in the urine. The oxygen is processed either into carbon dioxide or down into urine, and that is can be considered as K18. This gives us the formula where our CO2 in moles is equal to, as it's shown on the right side of the equation. And from this, you can easily calculate the basal metabolic rate. Additionally, the body composition can be calculated as well. Water is stored in lean body mass, but not present in fat mass. And we can use the same method to calculate lean mass. And this is the gold standard for calculating the body composition as well. Therefore, the physiological insight is that we measure static status of the body when you use a DEXA scan, whereas heavy water measures dynamic changes, and it identifies anabolic resistance and determines a metabolic rate. Therefore, if you truly want to treat metabolic dysfunction, you should measure the rate of turnover, not just the mass. Now, the pathology we're dealing with is sarcopenia, which is low muscle mass, along with obesity. That's basically sarcopenic obesity. What happens in obese individuals is the amount of skeletal muscle may go up, but the type of fiber changes. And because the type of fiber changes, then they can't function as efficiently. So they may have more muscle, but it doesn't work as well. Their gait speed goes down, skeletal muscle mass index goes down, body fat goes up. And there's some diagnostic criteria, as you can see on the right. So there's a vicious cycle. There's low muscle mass, reduces the basal metabolic rate, causes fat accumulation. There's increased fat mass. There's pro-inflammatory cytokines and muscle degradation. All of these processes lead to the engine failure. So basically, what happens is we are in a state of excess food intake. And when this excess food intake overwhelms the mitochondria where it cannot keep up and the engine cannot keep on producing ATP anymore, the reactive oxygen species are produced. These reactive oxygen species lead to damage to the mitochondria. And basically, the mitochondrial repair goes down. As this goes down, there's fewer mitochondria, a vicious cycle results. Additionally, adipose tissue secretes tumor necrotic factor alpha, interleukin 6, interleukin 1 beta, and all of these block protein synthesis. Therefore, at the cellular level, there is endocrine dysregulation in addition to this. There's a catabolic rise which promotes protein breakdown because of cortisol, myostatin, inflammatory cytokines, leptin resistance, etc. And then the anabolic crash, there's reduced protein synthesis because of growth hormone, testosterone, adiponectin, and all of this results in the obese phenotype. Now, if we think of dietary interventions, we tell our patients eat less and walk more. Let's consider. Now, the graph on the left shows a population study grouped by age and fat-free mass versus total energy intake. And as you can see, four distinct groups come out. The graph on the right shows that depending on various activities such as cycling, Arctic trekking, race across USA, etc., the basic metabolic rate goes up to about 2 times or 2.5 times, and then it plateaus. Therefore, as you exercise more, your body certainly burns more, but then it hits a plateau. Now, more active people certainly have a greater fat-free mass. Physical activity is a major determinant of body composition, but sustained energy expenditure plateaus at 2.5 times basic metabolic rate. A recent article in Current Biology illustrates this well. Their infographic on the left shows a sedentary lifestyle where activity burns some calories and other body processes burn more calories. Once activity increases, certainly there's a small increase in overall expenditure, but the other body activity component goes down and activity takes up more of those calories. Therefore, as you exercise more, the body modestly increases total energy expenditure, but other compensatory mechanisms kick in. Additionally, they found that if people eat less and exercise more, they may completely cancel the extra energy spent exercising. Now, this is an interesting insight. Going back to the caloric restriction is standard of care. Daily restriction of about, for example, 25% of kilocalories. It requires significant vigilance and tracking and frequent visits. Now, if we consider whether time-restricted eating is important or not, whether intermittent fasting, where the eating window is limited to 4 to 10 hours, typically 8 hours, is worthwhile. These things have been studied, and the verdict basically shows that there is essentially no difference in whether you do time restricted eating or caloric restriction alone. Um, However, time restricted eating may be easier as you don't have to track calories. Now, if you look at metabolic outcomes such as hemoglobin A1C and glycemic control, um, hemoglobin A1C was comparable in both groups, whether you do time restricted eating or caloric restriction. Both strategies yielded similar findings. Now, the utility is that you don't really have to count calories. Time restricted eating automatically decreases the amount of kilocalories you consume. So, if you limit the window of eating to 8 hours, it naturally reduces the dietary intake. Adherence is easier, and um, early time restricted eating may improve insulin sensitivity due to circadian peaks. That is, your body aligns with circadian peaks. Now, the mechanical intervention, you should remember exercise is medicine. Um, so you shouldn't think of it as calorie burning, you should think of it more as molecular signaling. The target is the mitochondria. Exercise is the only physiological stimulus capable of simultaneously increasing mitochondria quantity and quality. Um, so basically, contractile activity is a potent pharmacological agent on the myocyte. There are several molecular mechanisms. Essentially, there is more formation of new mitochondria and better restoration of function of mitochondrial function, and then restored DNA communication. And all these molecular mechanisms result just by exercising. Now, if you think of what we talked about earlier, exercise does increase calories modestly, but the body defends by decreasing the calories used for NEAT activities, and appetite increases. So, exercise alone gives you minimal weight loss. If you tell your patient, go to the gym, you lose weight, maybe they'll lose 3% weight at best. But exercise is good for composition, muscle retention, not just scale weight. Now, the kind of exercise also matters. If you diet only or use, for example, GLP-1 drugs only, there's a loss of lean mass and you become what you call skinny fat. The solution is resistance training. Resistance training stimulates mTOR, and time restricted eating plus resistance training reduces fat mass while preserving muscle thickness. Therefore, the resting metabolic rate or the basal metabolic rate is preserved. Now, nutritional support is also important. Several studies on South Asians in particular have shown that they have significantly low protein intake. It is very important to have a high protein intake. Survival minimum for protein intake is zero point 0.8 gram per kilogram. To prevent sarcopenia, it should be 1.2 gram per kilogram. Optimal is 1.6 to 2.4 gram per kilogram, which is a hard target to achieve unless you focus on nutrition. Further, when you take the protein is also important. Um, it's recommended to take it in pulses. Post exercise, if you take the protein, there's heightened anabolic sensitivity. If you take some pre sleep, it attenuates overnight muscle protein breakdown. So if you take about 0.25 to zero point 0.4 gram per kilogram per meal in 3 or 4 pulses, this is good. Now, if you have a diet that is high in unsaturated fat and low protein, then this is the amount of fat you take makes a difference. If you take Western high fat diet, it increases inflammation and causes toxicity. And if you do a fasting mimicking diet with high unsaturated fat, there is less IGF-1, and glucose. Therefore, there's a difference between healthy fat and high fat diet. Healthy fat would be like unsaturated protein, um, and Western diet is a high fat, which is bad for you. So the combined recommendation would be um, mild caloric restriction. We are possibly time restricted eating in an 8 to 10 hour window. Last meal of the day should be around 5 or 6 p.m. Focus on nutrient density, focus on macronutrients. Remember that high protein is a tissue protector. It's better to distribute it in 3 to 4 pulses. Exercise is important. Resistance training 2 to 3 times a day, 2 to 3 times a week, and aerobic zone, um, 2 high intensity interval training episodes. Therefore, you're really treating metabolism. It is not just about the scale. You move from weight loss to high quality composition change in the body. The strategy is that diet reduces the load, exercise upgrades the engine, protein provides the parts. Exercise acts as mitochondrial medicine that cannot be reproduced pharmaceutically. Now, once we move on to the talk on GLP-1, the importance of all of these is brought home. Here are some selected references. Thank you. That's all for now.